thank you for the introduction. So I'm a very newly appointed local consultant at St. George's, but this work is work that I did at the Royal Marsden for the last few years as part of a PhD. So it's a little bit about health inequalities and how we developed a model which is one small way of addressing some of these. So a little bit about deprivation. So deprivation is one of the most important determinants of life expectancy. So this is UK data, and you can see that from the most deprived to the least deprived groups, you've almost got a 10-year difference in life expectancy. Ethnicity links in with this because ethnic minority groups are disproportionately affected by deprivation. So what that means is if you're from an ethnic minority group, not all of them, but if you're from certain ethnic minority groups, you're more likely to be in a deprived population. So there is a connection between these two things, although that connection is not always clear. And cancer mortality increases with deprivation as well. And screening isn't the only solution for this because if you look at screening uptake, unsurprisingly, screening uptake is less in the more deprived groups. And this is just to sort of illustrate cancer mortality with deprivation, going from the least deprived to the most deprived. I don't need to talk too much about this to a room full of urologists, but it's just a slide on prostate cancer, particularly just illustrating the importance of early diagnosis, where you have much better outcomes than being diagnosed late with more advanced disease. So specifically with deprivation and prostate cancer, so there isn't a lot of data on this, although more is coming, but what you do have from cancer registration statistics and the National Prostate Cancer Audit is that you've got a higher mortality rate with increasing deprivation. That may be linked with a high risk of presenting with metastatic disease. Those are two statistics. Whether they're connected, I can say they probably are, but we don't have strong evidence for that. So delayed diagnosis is what the Man was trying to address and trying to promote early diagnosis. So a timeline of the project. It's nice to be speaking here in Leicester because actually the projects originated in Birmingham. So the man in the middle there is Professor Nick James, who's the PI of Stampede, who developed this project with one of his patients, Johnny who's that man on the left there. And Johnny presented to A&E in retention, found to have metastatic prostate cancer. I'm sure a story that everyone here is familiar with, and began asking why is there not more awareness for this? So they developed the idea, developed the project. Eventually, they did try to set it up in Birmingham. It didn't happen, but then Nick moved to the Marsden, and that's where we met and began the project. So how are we going to find these people? So part of the model of the Man Van is trying to go to locations where we think we'll find more high-risk men. So these are heat maps that are available as part of our Cancer Alliance. So this is RM Partners Cancer Alliance that covers Northwest London and Southwest London. So there is data available to show where the most deprived populations live and where different ethnic minorities live. And we just targeted those specific areas to try and get as much access to these high-risk men. We first ran a pilot in 2022, which I refer to as phase 1, before expanding the project in phase 2, which was part of a NHS England prostate cancer program and funded by NHS England. Just an overview of the model. So we used geospatial targeting based on the previous heat maps to try and find where we could find these high-risk men. We didn't use one communication method because we didn't feel any one communication method would reach all of these different groups. But we did work very closely with GPs. So we got GPs to send out text messages on our behalf. but also working with community leaders, church pastors. I've given a number of sermons in churches on Sunday mornings to try and just develop that groundswell of interest in the project. Then we booked appointments, and then the van moved to a particular area for 6 to 8 weeks. Seeing patients, and the health check that we did on the man van wasn't just a PSA for prostate cancer, it also included blood pressure, BMI, and an HbA1c for diabetes. And the reason for that is a lot of these men are at high risk of other health issues as well, not just prostate cancer. So whilst they're there, whether we can sort of increase the value of the project by offering a few other things. And any elevated PSAs were referred on a two-way pathway, not just to the Marsden, but also to all of the hospitals in the Cancer Alliance. So a brief overview of some of the phase 1 data. So we saw 600 men, so quite a small number. Almost half of these men were not white, 30% were black. And our pickup rate for prostate cancer was 3.6%, with most of these, but certainly not all of them, being clinically significant. So 10 out of 15 were clinically significant disease. And at that stage, we were more likely to diagnose black men based on these preliminary results. A bit more about this data. So as I've said, 30% of the men were black. The deprivation, so the average for us was in the 4th worst decile. So if you were expecting the average to be in the 5th, so we were definitely recruiting from more deprived groups. Already mentioned this, clinically significant disease, 2.5%. And as you can see, lots of other health issues, right? So these guys are not just there, being high risk of prostate cancer, diabetes, hypertension, obesity. These are all key issues that a lot of these men have. So we tweaked a few things for phase 2. We weren't that happy with our non-attendance rate. We thought that was a bit too high. And just the efficiency of the service, seeing 600 men in a year is not, we just didn't feel that was conducive to developing a project which could be implemented on a larger scale. So we wanted to increase the efficiency, which we did by reducing appointment times. And in phase 2, we saw almost 3,500 men, dropping our non-attendance rate to 15%. We did also reduce the number of men from ethnic minorities and black men, but still well above the background population that we were seeing. In this phase, with these numbers, we had a diagnostic rate of prostate cancer of 3.1%. The vast majority clinically significant, and no metastatic cancers. So how might this work long term? So part of what I've been doing is also looking at the health economics around this. And this is just an overview of how a primary care pathway might work and how our pathway worked. As you can see, it's the idea of this is to be much more streamlined, fewer appointments, less time taken away from GPs. The entire man was led by nurses. So it's not led by hospital consultants. It's not taking time away from hospital consultants. It's an entirely nurse-led pathway. As I'll show in the next slide, because it's nurse-led, this slide sort of looks at the costs of the project. Because it's nurse-led, the costs are much cheaper. And actually, based on our calculations, it's 25% cheaper to put a man through the man van versus put a man going to a GP practice to have a PSA test. So long term, it could be an alternative model, not just for prostate cancer, but for other health conditions as well. So in summary, we feel this is a novel approach to looking at health inequalities. We ran 2 phases, first initial phase and then a streamlined phase 2, which helps with the cost effectiveness. The economic value of the project is further boosted by the other health conditions that we found and ended up treating. And unlike previous studies, we've got high levels of ethnic minority participation, particularly Black men. And for those people that criticize testing because we're finding lots of insignificant disease, that's not what we found. Looking at a high-risk population, we found mostly clinically significant disease. Thank you very much.